Hello everyone. In this practical class, we'll learn clinical examination of a respiratory system. The requirements are stethoscope and measuring tape. Most of the systemic examination will be done under the following four headings, that is inspection, palpation, percussion and auscultation. In respiratory examination, during inspection, you have to look for the clubbing and cyanosis because most of the chronic respiratory disease, they will have a cyanosis or clubbing. Then shape of the chest. Normally the chest is bilaterally symmetrical and elliptical shape, where anteroposterior and transverse diameter, they are in the ratio of 5:7. The asymmetrical shape occurs in disease of lungs or bony cage, that is ribs or vertebrae. For example, barrel-shaped chest, which is usually seen in case of emphysema, and pigeon-shaped chest, which is seen with a vitamin D deficiency. And you also have to look for the spine for the scoliosis and kyphosis. Then respiratory movements of the chest has to be observed. Observe the equality of the respiratory movements on the both the sides. So then you have to calculate the respiratory rate, count the frequency of breathing for 1 minute without the subject's knowledge. The normal respiration is around 12 to 16 breaths per minute, and increase in the rate is called as tachypnea, and decrease in the respiratory rate is called as bradypnea. Then respiratory rhythm, comment whether it is regular or irregular, and you have to see the type of respiration, whether it is abdominothoracic or thoraco-abdominal. In case of males, it is abdominothoracic, and in case of females, usually it will be a thoraco-abdominal. Because of the lax costochondral junction in females, the respiratory cage is going to move with the lungs. Then you have to look for the use of accessory muscles of respiration during the normal breathing, especially the movements of sternocleidomastoid and scalene muscle. Then you have to look for the position of the apex beat. Apex beat is the outermost and lowermost point of the definite cardiac impulse, and note its approximate position, whether it is inside the mid-clavicular line or not. Then you have to look for the position of the trachea. Normally, trachea appears to be in the central. Then after palpation, you have to look for the position of the mediastinum, so which is determined by the examination of the position of the trachea and position of the apex beat. For the position of the trachea, keep the tips and index and ring fingers on sternoclavicular joints and trace the trachea in the midline with your middle finger till suprasternal notch. Insinuate middle finger between the trachea and sternocleidomastoid and feel for the space between trachea and sternocleidomastoid. Then for the locating apex beat, palpate the apex beat with the ulnar border of the right hand. Then locate the position with the tip of the middle finger or the index finger. Normally, the apex beat is in the left fifth intercostal space, ½ inch medial to the mid-clavicular line. This is how you're going to locate for the or palpate for the trachea. So you have to keep both your index finger and ring finger over the sternocleidomastoid and trace the trachea, or you have to insert your finger between sternocleidomastoid and the trachea to and feel the space between trachea and the sternocleidomastoid. Then apex beat has to be located using your ulnar border of the hand initially, so then with your index finger, and normally it should be just medial to the mid clavicular line. Then you have to palpate for the respiratory movements. Initially, the expansion of the chest has to be seen. It is done around the chest just below the level of nipples with measuring tape. In healthy adults, the expansion is around 4 to 8 centimeter. So then you have to assess the movements of the chest, and chest movements are examined in apical upper, middle and lower zone. And Before you try to look for the respiratory movements, ask him to take a deep breath while you are examining the movements. In apical zone, the two hands are located on the shoulders by the side of the neck from behind, with the thumbs approximated in the midline. As the subjects breathe in, observe the movements of the thumb. To examine the upper zone, the two hands are placed symmetrically on either side of the front of the chest in supramammary region. The thumbs are stretched so that they are either touching or equally away from the midline. And observe the movements of thumbs away from the midline. To look for the movements of the middle or lower zone, the procedure is same as above except for the position of the hands. Okay. Similar examination is carried out on the back in scapular and as well as in the intrascapular region. Okay. So this is how you have to check for the movements. Okay. So the thumb has to be approximated in the midline. For the checking of the expansion of the mid thorax, you have to place your hand like this and just observe the movement of the thumb as well as the movement of the other fingers which are covering the thoracic cage. Okay. So then posteriorly, this is how you have to test for the movement of the infrascapular area. Then tactile vocal fremitus. So here feel the vibration by the ulnar border of the hand when subject is asked to repeat 99 or 11 with the same intensity. Okay. And compare the intensity in the corresponding levels. Okay. So with the vocal fremitus, when he says 99 or 9, the vocal cord produces the sound waves which are pass through the lung parenchyma to reach the ulnar border of the hand. Okay. So if there is any abnormality in the lung parenchyma, then the quality of the vibrations, they are affected, and that is the principle behind the tactile vocal fremitus. Okay. So if air is replaced with the fluid in the lung parenchyma, then tactile vocal fremitus is increased, as it occurs in case of pulmonary edema or in case of lobar pneumonia. Note that the area of examination for vocal fremitus, percussion, auscultation, and vocal resonance are anteriorly supraclavicular, infraclavicular, mammary, and inframammary. Laterally, they are axillary and infraaxillary. Posteriorly, they are suprascapular, interscapular, and infrascapular on both the sides. Then coming to the percussion, where you're going to produce the percussion note. Note the percussion sound over the various lung fields and demarcate the lower border of the lungs. Okay. So methods of percussion are, it can be direct percussion or indirect percussion. In direct percussion, the finger strikes directly over the bony regions, that is, for example, clavicle, without the intervention of other finger, whereas indirect percussion is done all over the chest. So there are different percussion notes, so which can be resonant or hyperresonant, or they can be dull. Normally, all over the lung field areas where the alveoli are present, so there will be resonant. And if the air in the alveoli increases, so there can be hyperresonant note which can occur in emphysema. And if the alveoli are replaced with water or a fluid or solid substances, then it can be a dull note. How to do the percussion, and what should be the position of the hands during percussion? Okay, for the back, the subject leans forward with the head flexed and arms crossed in front. For the axillary and infraaxillary regions, both the hands of the subjects have to be kept over the head. Then percussion should always be done along the line in parallel of the intercostal space. Okay, so then percussion should always be from the area of resonance to the dullness, and percuss the lungs comparing the corresponding areas of the both sides. Okay, so these are the the rules of the percussion. Normally, the resonant note is elicited all over the lung. It is clear and high pitched. So this is how the percussion is done. So this is the pleximeter hand and this is the plexer. So you have to give taps on the middle phalanx, so with your middle finger, right middle finger. Okay, and these are the areas of percussion and they have to be parallel in the intercostal space. Okay, so these are the intercostal spaces, different intercostal spaces in the anterior chest and the lateral chest and the posterior chest and in the apical region. Boundaries of lungs. The apical percussion, the upper border is percussed in supraclavicular fossa anteriorly. The resonant note is obtained 3 to 5 centimeters above the clavicle. For the basal percussion, the lower border, during basal percussion, the lower border of the right lung lies at the 6th, 8th and 10th ribs in the mid-clavicular, mid-axillary and scapular lines respectively. Posteriorly, on both the sides and anteriorly on the right side, the percussion note changes from resonance to dullness, while anteriorly in the left side, the percussion note changes from resonance to tympanic. For the auscultation, you require a stethoscope, and with a stethoscope, you have to auscultate in all the lung fields, all the 9 areas, where you have to check for the air entry, where you see the intensity of the breath sounds. You have to look for the character of the breath sounds, whether they are bronchial or vesicular, when you are auscultating each lung fields. Then you have to look for the vocal resonance. It is very similar to the tactile vocal perimeters, but the difference is you are hearing the sounds with a stethoscope. Then you have to look for the adventitious sounds or added sounds or abnormal sounds of the lungs. So normally all over the lung fields, the vesicular breath sounds are heard. Okay, so these vesicular breath sounds, they are produced in the small airways and the alveoli, so which are low pitch sound. They are soft and rumbling soft and rumbling and rustling sounds. Whereas the bronchial breath sounds, they are produced in the larger airways, and it has a very high pitch and it is harsh. So there is a definite pause between the inspiration and expiration with the bronchial breath sound, whereas vesicular breath sounds, they are continuous. Then the ratio of inspiration to expiration is equal with the bronchial breath sound, whereas the expiration is less compared to the inspiration in vesicular breath sound. Okay, so you can observe here in the vesicular breath sound, which is the continuous sound, and inspiration is prolonged and expiration is short and there is no gap. Whereas the bronchial breath sound, there is a definite gap between the inspiration and expiration, and the time required for inspiration and expiration, it is the same. Okay. So whenever you hear bronchial breath sound over the alveolar lung fields, it is always abnormal. Normal areas of bronchial types of breath sounds, apart from the lung field area, it can be best heard over the trachea and the sides of the lower cervical vertebra. The normal areas for vesicular breath sound, it can be heard over the lung fields. Then coming to the vocal resonance, which has a principle similar to the TVF, asks the subject to say slow, loud and uniform voice 99 or 11. It is heard using the stethoscope and compare the intensity on the corresponding areas of the chest. Okay, so as I mentioned, the vocal resonance is going to increase in cases where the air is replaced with fluid, in cases like pulmonary edema and in lobar pneumonia. And the vocal resonance is going to decrease whenever there is excess mass in between in the parenchyma or in the pleura, like in case of pleural effusion, hydrothorax or pneumothorax. Then the report should be written in the following manner. Okay, so you have to write in all the headings like inspection, palpation, percussion and auscultation. In inspection, you must mention the shape of the chest, position of the trachea, whether it is central, then respiratory rate, the respiratory rhythm, the type of respiration, and in palpation you have to confirm these findings where you will be confirming the position of the trachea, position of the apical impulse which is just medial to the mid-clavicular line in the left side. You have to measure the chest expansion in centimeters. Then you have to mention about the chest movements, the apical or and middle zone, lower zone, and the in posteriorly the infrascapular area. Okay, and enter your observation as per the areas mentioned, that is all the 9 areas of the observation. Okay, so then you have to mention about the tactile vocal fremitus in the all lung fields. Then percussion has to be noted in the all the lung fields, whether it is resonant or hyperresonant or dull. Then in auscultation you have to look for the air entry, type of breath sounds, whether they are vesicular or bronchial breath sounds, and you have to mention about the vocal resonance, whether they are equally heard on the both the sides. Then you should mention about the adventitious sounds, that is the crepitations or rails or rhonchi or V's. Okay. To mention here, there can be different type of percussion notes. So resonant percussion is heard over the normal lungs wherever there are alveoli beneath. Hyperresonant, it can be heard in the pneumothorax or it can be emphysema. Dull note is observed in pulmonary consolidation, pulmonary collapse, and severe pulmonary fibrosis. Okay. Whereas stony dullness is heard during pleural effusion and hemothorax. Okay. So you can hear the woody dullness in case of the pulmonary consolidation, where there is a consolidation of the lobe which occurs because of the pneumonia. Some of the adventitious sounds are crackles or the rails or the crepitations. All are synonymous and they occur because of the presence of the fluid in the alveoli. Okay, and these are called as crepitations, crackles or rails. Okay, so rhonchi occurs whenever there is an obstruction to the expiration during expiration. So there will be musical sound produced because of the resonance which is created in the tracheobronchial tree. Okay, so when they are heard with the stethoscope, they are called as rhonchi, and when they are observed or heard with your naked eye, so then it is called as V's. Okay, and stridor is obstruction of the respiratory tract because of the foreign bodies. So there can be abnormal sounds during inspiration or expiration. Okay, so again pleural rub, it is a crackling type of sound produced because of the pleuritis. So these are some of the adventitious sounds that should be observed during respiratory examination. So this is in brief about how the clinical examination of the respiratory tract is done. Thank you.